So, I want you to picture this. You are standing right here with us at the lab bench.
Right. Right in the thick of it.
Exactly. Surrounded by, the hum of centrifuges and all the mass spectrometers. And I want you to look at this readout on the analyzer. Just focus on this one single line for a second.
The one flashing in red.
Yeah, that's the one. So we've got this 62-year-old male, completely asymptomatic, right? Just came into the clinic for his routine physical.
Standard checkup.
Right. And the physician ordered a comprehensive metabolic panel and a prostate-specific antigen test, the PSA.
Which is pretty standard for his age, yeah.
Definitely. And the reference range for PSA at 62, it tops out around like 4.0 nanograms per milliliter. But this result that just flashed across our screen, it's sitting at 7.5.
Oof. Yeah, that's a number that gets people's attention.
It really does. I mean, in a patient's mind, and honestly, often in a primary care doctor's mind too, that red number on the screen is just a flashing siren.
Oh, absolutely.
It feels binary to them. Like you're either healthy or you have cancer. There's no in between.
Which is, I mean, it's the absolute furthest thing from binary. That 7.5, it's just a classic example of diagnostic noise.
Diagnostic noise. I like that.
Yeah, because, you and I are standing here looking at this serum, and we know that a single elevated glycoprotein level is, well, it's essentially just a biological whisper.
A whisper, yeah. It's not shouting a diagnosis at us.
Exactly. It tells us that the cellular architecture of this man's prostate is compromised in some way, but it absolutely does not tell us what compromised it.
Right.
I mean, we are just looking at the echoes of cellular activity here. We aren't looking at the disease itself.
That is just the perfect framing, because as medical lab professionals, we essentially live in this murky territory every single day.
We really do.
And that's exactly why we're doing this deep dive today. We spend our lives interrogating these exact types of results. And joining me in this diagnostic interrogation is someone who knows this better than anyone.
Well, I try.
A seasoned veteran of clinical pathology and a consultant at Skill Hub, right?
Yeah, that's right. Skill Hub down in Kenya.
Right, the CPD provider accredited by the Kenya Medical Laboratory Technicians and Technologists Board. So you literally train professionals to look past these isolated data points.
I do, yeah. Because like you said, that 7.5 PSA, it has the power to unleash an absolute cascade of medical interventions.
And some of those interventions might be completely unnecessary.
Completely unnecessary,
Yeah.
and frankly, deeply harmful. Before we decide the fate of this 62-year-old man, we really need to strip away all those assumptions and just look at the underlying biochemistry.
So let's unpack this. When we talk about tumor markers, what are we actually looking for in that tube of blood?
Well, we are hunting for specific biological substances. So that could be proteins, enzymes, hormones, even genetic fragments.
Things that are floating around in the serum.
Right. Substances that are elevated in the presence of a malignancy. But, and this is the critical flaw in how the public understands these markers.
The idea that they are only made by cancer.
Yes. The assumption that they are exclusively produced by tumors. They aren't these unique, villain signatures.
Right, they aren't wearing little name tags that say, "Hi, I'm cancer," because cancer cells are fundamentally just our own normal cells, right? Just with corrupted source code.
That's exactly it. They don't usually invent entirely new alien proteins out of nowhere.
They just inappropriately manufacture normal human proteins, like at the wrong time or in totally the wrong quantities.
Precisely. Let's look at uncoated antigens, for example, like alpha-fetoprotein or carcinoembryonic antigen, CEA.
Oh, those are fascinating because those are absolutely vital during fetal development, right?
Exactly. When a baby is growing in the womb, these proteins are essential. But once the baby is born, the genes responsible for producing them, well, they undergo this process called epigenetic silencing.
So the body basically chemically tags the DNA and locks those blueprints away.
Yes. It's like putting those specific genetic blueprints into a secure vault, because the adult body simply doesn't need them anymore.
Okay, but then a malignancy develops, right, decades later.
Right. And the cancer cell, it undergoes this chaotic cellular dedifferentiation.
So it sheds its mature identity. Say it was a highly specialized liver cell, it just sort of forgets how to be a liver cell.
Exactly. It reverts back to this primitive, almost embryonic state. And in that chaotic regression, those epigenetic locks on the vault, they get broken.
The DNA methylation patterns get stripped away.
Yeah. So the cell begins wildly translating those ancient fetal blueprints all over again.
Wow. So seeing elevated alpha-fetoprotein in a 50-year-old adult serum, it's this massive biochemical red flag because adult cells simply shouldn't be reading from that chapter of the genetic manual.
Exactly. It should be accessible.
It's almost like the tumor is performing a factory reset on the cell.
A factory reset is a great way to put it.
Yeah.
And, we see similar rogue behavior with enzymes, too.
Because tumors are hypermetabolic, right?
But massively. They undergo what we call the Warburg effect. They consume just absurd amounts of glucose.
Right, they run their cellular machinery at this breakneck pace, even when there's plenty of oxygen around, just to sustain that crazy rapid cell division.
Exactly. And the consequence of that hypermetabolism is that we see elevated levels of certain enzymes, things like lactate dehydrogenase or alkaline phosphatase, just spilling out into the blood.
Okay, but here's where it gets tricky for us in the lab. Alkaline phosphatase isn't just produced by bone or liver tumors, is it?
Not at all. It is produced by perfectly healthy osteoblasts during totally normal bone remodeling.
So if a patient is just recovering from a broken arm,
Or if they have Paget's disease.
oh,
Or, frankly, even if it's just an adolescent going through a totally normal growth spurt.
their alkaline phosphatase levels will be sky high, and it has absolutely nothing to do with cancer.
Exactly. So completely benign. And we see this same kind of dilemma with ectopic hormone production.
Oh, ectopic hormones, like when tumors just start making hormones they have no business making.
Right. We frequently see this with small cell lung cancers. They somehow acquire the ability to secrete adrenocorticotropic hormone, ACTH.
Wait, but ACTH is normally produced strictly by the pituitary gland in the brain, right?
Yes, strictly the pituitary. So you end up with a lung tumor that is essentially impersonating the pituitary gland,
It's flooding the body with ACTH,
which then drives the adrenal glands to massively overproduce cortisol.
resulting in this sudden onset of Cushing's syndrome. So you have a patient showing up with rapid weight gain, high blood pressure, their skin is thinning.
And the doctor might be looking at the adrenal glands or the brain, but the root cause is actually a microscopic cluster of rogue cells down in the lungs.
It's just wild. And this really leads us to this whole myth of the ideal tumor marker.
Oh, the mythical ideal marker.
Right. Like, in theory, an ideal marker would have 100% sensitivity, meaning it never, ever misses a true cancer case.
And it would have 100% specificity, meaning it never falsely flags a perfectly healthy person.
And on top of all that, it would have to perfectly correlate with the tumor burden. So we could just look at the blood level and know exactly how big the physical mass of the tumor is.
It sounds wonderful, doesn't it?
It does. But I mean, that theoretical marker totally ignores the messy reality of human biology.
Completely ignores it because, we aren't standardized machines off an assembly line.
Baseline biochemistry shifts radically, doesn't it?
Yeah.
Based on age, sex, your genetic ancestry.
And underlying chronic inflammation. People walk around with varying levels of baseline inflammation all the time.
So if we try to apply this rigid universal threshold like saying any PSA over 4.0 is definitely cancer, we are mathematically guaranteeing false positive.
Guaranteeing them. Which brings us right back to our 62-year-old patient, the guy with the 7.5 PSA.
Let's get back to him. So prostate-specific antigen is a glycoprotein. What is it actually supposed to be doing in the body?
Well, its normal physiological function is to liquefy the seminal coagulum after ejaculation. Basically, it aids sperm motility.
Okay. And it's made by the prostate.
Specifically, it's synthesized by the epithelial cells that line the Achenian ducts of the prostate gland.
Right. And under normal, healthy conditions, that glandular architecture is really tight, isn't it?
Very tight. There is this basement membrane that acts as a solid physical barrier. It ensures that the vast majority of the PSA is secreted inward, directly into the prostatic ducts.
So only tiny trace amounts should ever actually leak out into the bloodstream.
Exactly. So for the serum PSA level to rise all the way to 7.5, something has to disrupt that basement membrane.
The physical barrier has to be breached.
Right. And yes, a highly aggressive prostatic adenocarcinoma certainly does that.
Because those malignant cells, they destroy the basal cell layer, they invade the surrounding tissue, and the PSA just leaks right out into the capillaries.
It does. But, and this is the crucial part, sheer physical volume also plays a role. And this is where benign prostatic hyperplasia, or BPH, totally muddies the waters for us.
Right, BPH. Because as men age, the prostate just naturally gets bigger.
It does. The transition zone of the prostate enlarges, and BPH is absolutely not cancer.
Just extra normal cells.
Exactly. It is simply a hyperproliferation of benign glandular and stromal cells. However, more prostatic tissue naturally produces more PSA. It's just a volume game.
And doesn't that enlarging tissue also kind of stretch everything out?
Yes. It compresses the urethra, and it physically stretches the surrounding vascular networks. That mechanical stretching increases the permeability of the tissue.
So even more PSA leaks into the blood just from mechanical pressure?
Precisely. And then we also have to consider prostatitis.
Which is just an inflammation or infection of the gland, right?
Right. An influx of white blood cells responding to an infection that causes localized tissue edema, cell death, and a profound disruption of that epithelial barrier.
Wow. So a bad bacterial infection could cause a huge spike.
A severe acute prostatitis can drive a PSA up to 30 or 40 nanograms per milliliter.
30 or 40. That would mimic a widely metastatic cancer, easily.
It would look terrifying on a lab report.
Right.
And this is why the fallout of treating that 7.5 strictly as a cancer indicator is just immense.
Walk us through that fallout. What happens next to this patient?
Well, the primary care physician sees the 7.5. They panic a bit, understandably, and refer the patient to a urologist.
Yeah.
The urologist looks at the number and schedules a transrectal ultrasound-guided biopsy.
Which is, I mean, let's be honest, that is not a mild, benign procedure.
Not at all. They insert an ultrasound probe into the rectum, and then they fire a spring-loaded needle through the rectal wall directly into the prostate.
Oh, man. And they do that, what, like 10 or 12 times?
Usually 10 to 12 core samples, yes.
You are pushing a needle through a totally non-sterile environment, the rectum, and plunging it into a highly vascularized organ.
The risk of sepsis is real. Severe hematuria, bleeding into the urine. Temporary urinary retention. It's physically traumatic.
But honestly, the physical risks almost pale in comparison to the psychological devastation.
The psychological toll is staggering. Think about that patient. For the entire month leading up to that biopsy appointment, and then the agonizing weeks waiting for the pathology report to come back.
They are mentally preparing for their own mortality. I mean, they are probably writing their will in their head.
Exactly. And then the pathology report finally comes back. The Gleason score is 0.
0. No malignant cells identified anywhere.
None. The patient simply had asymptomatic mild prostatitis combined with some totally age-appropriate BPH.
So we basically subjected a perfectly healthy man to a painful, risky, and super expensive procedure purely because our frontline screening test lacked specificity.
We call it overdiagnosis.
Yeah.
And it is a literal epidemic in modern laboratory medicine.
So then I have to ask, why are we still running it? I mean, if the specificity is really that poor, if we know we are causing this much collateral damage and anxiety just chasing benign ghosts,
well,
why don't we retire PSA testing altogether?
That's a fair question. It feels negligent.
Yeah, it feels crazy to keep using a flawed tool.
We don't retire it because the alternative is so much worse. The alternative is missing aggressive lethal adenocarcinomas until they have already metastasized to the bone.
And by then it's often too late.
It is. When PSA testing was widely introduced in the late 90s and early 2000s, it radically reduced the mortality rate of prostate cancer.
So the test itself isn't the failure?
No, the failure is not the assay. The failure is the clinical interpretation. We, as a medical community, placed way too much diagnostic weight on one isolated data point.
We basically treated a single snapshot as if it were the entire movie.
That's a great analogy.
In the lab, we rely on longitudinal follow-up, right?
Yeah.
Because time is the ultimate filter for biological noise.
Time is everything. Let's rethink how we track these markers.
I always think of an isolated PSA result, kind of like a single sonar ping in a massive ocean. You know, you hear a blip.
Right.
It could be an enemy submarine, but it could also just be a whale. Or even just a thermal layer bouncing the sound wave back.
Exactly. You don't fire a torpedo based on one single ping.
You keep tracking. You ping it again.
You map the trajectory. So let's apply that active surveillance model to our patient.
Okay, so he comes in with the 7.5.
Right, we see the 7.5. But instead of jumping to a biopsy, the doctor prescribes a course of anti-inflammatories, or maybe antibiotics, targeting a potential silent prostatitis.
And we tell him to come back in, what, 6 weeks?
6 weeks is good. He comes back, we draw blood, we run the assay again. This time it's 5.2.
Okay, it's dropping.
We have him return 3 months later, we run it again, it's 4.1.
So the trend line is clearly downward.
Right. And we know the biological half-life of PSA in the serum is roughly 2 to 3 days.
So as the inflammation goes down and the gland heals its architecture, the liver is just steadily clearing that excess glycoprotein out of the blood.
And the levels normalize. We've effectively ruled out cancer, and we never even had to touch a biopsy needle.
That is the power of trending. But conversely, if that trend went from 7.5 to 9.2 to 14.8 over that same time frame,
and we are looking at exponential growth. A sustained upward velocity strongly correlates with the uncontrolled cellular division that characterizes a malignancy.
The trend line gives us the context that the isolated number is missing.
Exactly. And this principle, trending over time, it is the absolute cornerstone of post-treatment monitoring across all of oncology.
Let's talk about CA-125, specifically in the context of ovarian cancer, because that really highlights this.
Oh, absolutely. Ovarian malignancies are incredibly insidious.
Because they grow in that vast open space of the peritoneal cavity, right? So they don't cause early localized pain.
Right. They often present with just these really vague symptoms. Mild bloating or, early satiety, getting full quickly when you eat.
Which, patients naturally just attribute to diet changes or just getting older.
Totally normal things to assume. So by the time a physical mass is finally discovered, it is frequently quite advanced.
And then the standard of care is usually cytoreductive surgery, right?
Yes. The surgeon goes in and performs a debulking procedure, removing as much of the tumor mass as physically possible, and that's usually followed by aggressive chemotherapy.
So where does the lab come in?
We measure the patient's CA-125 preoperatively. That establishes our baseline.
Say it's up in thousands.
Right. Then, postoperatively, we monitor the clearance. If the surgery and the chemo were successful, we should see a logarithmic decay in the serum concentration.
Mirroring the protein's natural half-life.
Exactly, until it finally reaches a stable nadir, a low point.
But the surveillance doesn't stop there. The patient keeps coming in every few months for blood draws.
And if we see that CA-125 level plateau, and then, just slowly begin to tick upward.
Even if the numbers are technically still sitting inside the normal reference range, right?
Yes. Even if it goes from 10 to 15 to 22. That subtle upward trajectory is often the very first biochemical indicator of minimal residual disease.
The cancer is recurring.
It is recurring.
Yeah.
And that rising blood trend will precede any visible evidence on a CT scan or an MRI by months.
Months. That's incredible because the malignant cells are multiplying and shedding the antigen into the blood way before they form a physical mass large enough for a radiologist to spot.
Exactly. However, we do have to integrate these biochemical trends with the patient's holistic clinical picture.
Right. We can't just look at the numbers in a vacuum. We have to consider their pharmacokinetics.
How the body is actually clearing the waste.
Right, because if a patient is undergoing a really harsh chemotherapy regimen, we might be inadvertently causing nephrotoxicity. We might be damaging their kidneys.
Which is very common. And most tumor markers, since they are relatively small proteins or just peptide fragments, they are filtered out of the blood by the renal glomeruli.
The kidney's filtration system.
Right. If the patient's glomerular filtration rate drops because of that kidney damage, their ability to excrete the tumor marker just plummets.
So it just builds up in the blood?
Yes. The serum concentration of the marker will rise, artificially simulating a tumor recurrence.
Wow. So if the oncologist is only looking at that one lab value on a chart, they might completely misinterpret it.
They might assume the cancer is progressing,
Right.
and they might switch the patient to an even more toxic chemotherapy regimen.
When in reality, the patient just has a plumbing issue. The kidneys are failing, causing the proteins to back up.
Which is why this requires intense, constant collaboration between the laboratory, the pathologist, the radiologist, and the attending oncologist. We all have to talk to each other.
But none of this highly calibrated trending, none of this collaboration even matters if the raw data coming off our analyzers is corrupted from the very start.
Oh, don't get me started on pre-analytical errors.
We have to. We have to take you behind the scenes into the pre-analytical phase because the harsh reality of the lab bench is that a tiny microscopic handling error occurring in some phlebotomy clinic miles away.
It can completely invalidate the most sophisticated technology we possess.
It's terrifying, so let's talk about it.
Well, the pre-analytical phase is basically the dark matter of laboratory error. It accounts for up to 70% of all diagnostic mistakes.
70%, that's huge. And we are talking about the actual physical mechanics of the blood draw itself.
Yes, let's look at sample hemolysis. It is the absolute bane of clinical chemistry.
Let's break down the sheer physical violence of a bad blood draw because people don't realize how delicate cells are.
They really don't. Think of a red blood cell as a highly pressurized microscopic water balloon.
Packed full of hemoglobin, potassium, and an array of intracellular enzymes like lactate dehydrogenase.
Exactly. Now, if a phlebotomist uses a high-gauge needle, meaning the needle is too narrow, and they pull that syringe plunger back aggressively to draw the blood out really quickly.
They create a massive vacuum inside the
A
syringe.
huge vacuum. And the sheer hydrodynamic force of those delicate cells being sucked forcefully through that tiny metal aperture, it physically shreds the lipid bilayers of the red blood cells.
The balloons just burst.
They rupture completely. So the serum, which, once we spin down the intact cells in the centrifuge, it should be this clear, pale yellow fluid.
Like straw-colored.
Right. But instead, it turns bright cherry red because it is flooded with free hemoglobin.
And that cherry red sample totally destroys our traditional immunoassays. The ELISAs and CLIAs that are the absolute workhorses of the lab.
It ruins them.
Let's detail exactly why a red sample ruins a chemical test. Because these automated platforms, they often rely on spectrophotometry, right?
They do. They pass a highly calibrated beam of light through the little sample well, and they measure the absorbance, or the transmittance, to quantify the color change generated by the chemical reaction.
And hemoglobin absorbs light intensely at very specific wavelengths.
So if the serum is flooded with hemoglobin from those ruptured cells, that hemoglobin acts like a dense fog.
It scatters and absorbs the light beam.
It does. The analyzer is effectively blinded. It registers this massive absorbance reading, and its algorithm incorrectly translates that dark fog into an astronomically high tumor marker concentration.
So you generate this catastrophic false positive purely because of mechanical shear stress in the needle.
It's a mechanical failure disguised as a biological crisis, and it gets worse.
How does it get worse?
Well, those intracellular enzymes that spilled out when the cell burst, the protease, they are highly destructive.
Oh, right. Because their job is to break down proteins.
Yes. They can physically cleave the delicate capture antibodies that we use to bind the tumor marker in the assay.
Or they might just cleave the tumor marker protein itself. Just chop it up into pieces that our antibodies don't even recognize anymore.
And in that scenario, you generate a false negative.
The patient's serum is actually teeming with the tumor marker, but the proteases destroyed the evidence before our machine could read it.
Exactly. The patient is told their blood is clear while a malignancy is silently progressing.
This is why a diligent lab tech has to visually inspect every single specimen tube.
We have to. We must aggressively reject hemolyzed samples, even if it means inconveniencing the patient by calling them back for redraw.
Because the alternative is charting a lethal lie.
It is.
Yeah.
Now, assuming we do have a pristine, perfectly handled sample,
The golden tube.
right, we move into the analytical phase,
Yeah.
and we really need to dissect the chemistry of these immunoassays because they are brilliant, but they are inherently vulnerable.
Take a LASA, enzyme-linked immunosorbent assay. We rely on the profound biological specificity of monoclonal antibodies.
We basically synthesize an antibody in the lab that is genetically engineered to recognize and bind to one specific epitope.
An epitope being a microscopic specific sequence of amino acids on the surface of our target tumor marker, like a highly specific puzzle piece.
Exactly. And the sandwich assay architecture is the standard here.
Okay, build the sandwich for us.
We coat the bottom of a microscopic plastic well with millions of these capture antibodies. They are anchored there.
Okay.
We introduce the patient's serum into the well. If the target antigen is present, it floats down and binds to the capture antibody.
Like a lock and key. Then what?
Then we perform a wash step. We literally wash the well out to remove all the other tens of thousands of irrelevant serum proteins that we don't care about.
Just leaving the target stuck to the bottom.
Right. Then we introduce a second distinct antibody, the detection antibody.
Which binds to a different epitope, a different puzzle piece, on that same target molecule.
Sandwiching the tumor marker right in the middle.
Okay, but how do we see it? Because this is all microscopic.
That detection antibody has a specific enzyme covalently linked to its tail. So finally, we add a chemical substrate. The enzyme on the tail cleaves the substrate, and that produces a vibrant color change in the liquid.
And the optical density, basically how dark that color gets, is directly proportional to how much tumor marker was in the sample.
Exactly. Chemiluminescence immunoassays, or CLIAs, use a very similar sandwich principle, but instead of a color change, they utilize a luminescent chemical that produces a flash of light.
Which allows for even greater sensitivity, right? Because we just measure the photons emitted.
We do, and they are magnificent feats of biochemical engineering. They can detect proteins down to picograms per milliliter.
They have a critical structural weakness.
They do. Cross-reactivity.
Because no antibody is ever perfectly 100% specific.
Never. Sometimes A completely unrelated benign protein, or even, a metabolite from an over-the-counter vitamin supplement.
Like biotin.
Biotin is a massive interferent, yes. They happen to possess an amino acid sequence that structurally mimics our target epitope.
The puzzle piece looks similar enough to fool the system.
The capture antibody is fooled. It binds the imposter molecule, the sandwich forms, the enzyme triggers the color change.
And the analyzer spits out a severe elevation. Another false positive. But there's another vulnerability too, right? The high-dose hook effect.
The prozone effect, yes.
Yeah.
This one creates a terrifying false negative.
Walk us through the chemistry of the hook effect, because it sounds totally counterintuitive. You have a huge tumor, but the test reads 0.
It is counterintuitive. So the hook effect occurs when the patient has a massive advanced tumor burden and their serum is just absolutely saturated with the tumor antigen.
Millions of target molecules.
Right. So when we add that highly concentrated patient sample to our little well, the concentration of the antigen is so overwhelmingly high that it immediately saturates all the capture antibodies on the bottom of the well.
Oh, okay. All the bottom anchors are full.
But there are still millions of free antigens floating in the liquid. So when we add the detection antibodies, they immediately bind to those free-floating antigens up in the solution.
Wait, so the bottom antibodies are full and the top antibodies are full independently?
Yes. Because both antibodies are completely saturated independently, the full sandwich cannot form. They can't link together.
It's like a crowded room where everyone is holding an apple, so nobody has a free hand to hold hands with each other.
Perfect analogy. They can't connect. So when the wash step occurs, those saturated detection antibodies floating in the liquid, they just get flushed right down the drain.
Because they aren't physically anchored to the bottom well.
Exactly. The machine then reads 0 color change, and it reports a clinically insignificant level of the marker.
While the patient is actually riddled with metastatic disease.
Yes. The laboratory has to constantly dilute high-concentration samples and rerun them just to ensure we aren't being deceived by this chemical paradox.
It's exhausting just thinking about it. All these workarounds for analog chemistry.
Which is precisely why the field of oncology is aggressively pushing past immunoassays entirely.
We are entering the era of next-generation sequencing, NGS.
We are. We are transitioning from the analog reading of downstream protein echoes to the digital certainty of the genetic source code.
I mean, when I look at the bioinformatics pipeline of NGS, it literally feels like we've jumped a century in technological advancement.
It really does.
With an ELISA, we ask a simple binary question. Is this specific protein shape present?
Right.
But with NGS, we are extracting the raw DNA or RNA directly from the tumor cells.
We extract it, we fragment it into millions of tiny pieces, and we sequence every single nucleotide simultaneously.
We aren't just looking at the paint on the walls anymore. We are auditing the architectural blueprints of the cancer cell to find the exact typo that caused the structure to collapse.
We map the entire mutational landscape. We identify the specific single nucleotide polymorphisms, the gene fusions, the insertions, the deletions.
All the specific genetic drivers pushing that uncontrolled proliferation.
Exactly. We are moving away from diagnosing a generic lung cancer to diagnosing an ALK fusion positive ROS1 negative adenocarcinoma.
It's hyper-specific. But, okay, the temptation here is to ask, if NGS gives us this absolute, definitive molecular truth without any risk of antibody cross-reactivity or those weird hook effects.
Why are we still using ELISA?
Yeah. Why isn't every single patient walking into a clinic getting a full genomic audit of their blood?
Well, the barriers are massive. They are logistical, computational, and highly financial.
Let's start with computational.
That bioinformatics pipeline you mentioned, it is staggering. An immunoassay gives you a single numerical value, 7.5. Done.
Right.
A comprehensive NGS panel generates terabytes of raw data in these massive FASTQ files.
Terabytes from one tube of blood.
Yes. You need massive supercomputing clusters just to process it. You have to align those millions of short DNA reads against the reference human genome.
Just to find where the sequence is broken. And then you run into the variant calling problem, don't you?
Oh, the variant calling problem is huge.
Yeah.
You will inevitably find thousands of mutations in any sample, but the vast majority of them are what we call VUS, variants of unknown significance.
So they are genetic typos, but they don't actually change the function of the cell.
Right, like spelling color with a U. It looks different, but it means the same thing. It doesn't break the gene.
So if we ran NGS on everyone, we would just drown oncologists in an ocean of completely meaningless data.
They would spend hours agonizing over some random mutation on chromosome 7, having absolutely no idea if it's the driver of a lethal tumor or just a harmless evolutionary quirk.
The interpretative burden is just immense. You'd need a dedicated tumor board of bioinformaticians, geneticists, and oncologists for every single patient just to separate the driver mutations from the passenger mutation.
Exactly. And then, of course, the sheer cost is currently prohibitive for frontline screening,
We're talking thousands of dollars per panel, right?
compared to maybe $20 for a standard immunoassay. So we deploy NGS surgically. We use it for complex, advanced cases where standard therapies have failed, and we really need a precise molecular map to guide targeted interventions.
Let's talk about those molecular targets, actually, because this transition from proteins to genetics, it radically alters how we view cancer risk and treatment.
It does. It changes the whole paradigm.
The most profound examples that the public actually kind of knows about are the BRCA1 and BRCA2 genes.
Which are fundamentally misunderstood by almost everyone.
Right. People always refer to them as the breast cancer genes, right? They assume that simply having the gene causes the cancer.
Which couldn't be further from the truth. BRCA1 and BRCA2 are actually tumor suppressor genes.
Their job is to stop cancer.
Exactly. Their primary physiological role is to maintain genomic stability by facilitating homologous recombination repair.
Let's use a structural analogy for this, because homologous recombination is a mouthful.
Go for it.
Imagine your DNA is a massive suspension bridge. Throughout the day, just from environmental radiation, metabolic oxidative stress, normal replication errors, the support cables randomly snap.
These are double-strand DNA breaks. Very dangerous.
Right. And the BRCA proteins, they are basically the elite repair crews.
They are.
They rush to the snapped cable, they use the undamaged sister chromatid as a pristine template, and they perfectly reconstruct the broken section. The bridge holds.
A perfect repair. But if a patient inherits a germline mutation in one of these BRCA genes, their elite repair crew is heavily compromised.
They're working with half a crew.
Right. So as they age and their cells naturally accumulate these double-strand breaks, they cannot execute that precise homologous recombination repair.
So what happens to the bridge? Does it just fall?
No, the cell is forced to rely on a secondary, highly error-prone emergency repair mechanism called non-homologous end joining.
Okay, so it's like patching that snapped steel cable with duct tape and some zip ties.
That is exactly what it's like. It keeps the bridge from collapsing immediately, sure, but it introduces massive structural errors.
And over time, those errors accumulate rapidly.
They inevitably knock out other critical genes, they mutate the gas pedals of the cell, the oncogenes, and they drive the cell into unchecked malignant division.
And that is why the lifetime risk for breast and ovarian cancer skyrockets for those patients.
Yes, but understanding this exact mechanism, it allows us to exploit it therapeutically.
Oh, this is the brilliance of synthetic lethality. I love this concept.
It's elegant, isn't it? If we know a patient's tumor has a BRCA mutation and therefore lacks that primary repair crew, we can administer a targeted drug called a PRP inhibitor.
And PRP is just an enzyme that handles a totally different type of DNA repair, right? Single-strand breaks.
Right. So the tumor cell is already limping along with a broken BRCA system. It is relying entirely on the PRP system just to survive its own chaotic, messy replication.
We'd administer the PRP inhibitor, and we effectively knock out their secondary backup repair mechanism.
The duct tape is gone. The tumor cell's DNA sustains catastrophic damage, it can't replicate, and it triggers apoptosis. Cellular suicide.
Meanwhile, the patient's healthy cells, which only have one mutated BRCA copy, they still have enough baseline function to survive the PRP inhibition.
They tolerate it. We are precisely targeting the specific molecular vulnerability of the cancer while sparing the healthy tissue.
But this precision, it really relies on our ability to monitor the tumor's genetic profile in real time, which ushers in what I think is the most revolutionary advancement in modern diagnostics.
Liquid biopsy.
Yes, liquid biopsies and the analysis of circulating tumor DNA, or ctDNA.
It is a game changer.
I mean, this concept feels like pure science fiction. We are no longer plunging huge needles into deep tissue masses to extract physical cells.
No, we are drawing a standard, basic tube of peripheral venous blood to sequence the tumor's entire genome.
Okay, we have to explain the biomechanics of this. How do fragments of a solid liver mass or a lung mass end up floating freely in the plasma of the blood?
It really comes down to the chaotic microenvironment of the tumor itself. Tumors are highly disorganized structures. They frequently outgrow their own neovascular supply.
They grow faster than they can build blood vessels.
Right, so the cells at the very core of the mass, they become hypoxic. They're starved of oxygen and nutrients.
And so they undergo necrosis.
Yes, they rupture and they spill all their intracellular contents, including their DNA, directly into the surrounding stroma.
Okay, that's one way.
Furthermore, the patient's own immune system is constantly attacking the periphery of the tumor, right?
Trying to fight it off.
And that immune attack induces apoptosis, or programmed cell death, which causes the malignant cell to neatly fragment.
So in both scenarios, necrosis and apoptosis, the DNA of the cancer cell is getting chopped up.
Chopped up into tiny, small fragments, typically around 166 base pairs long.
And these microscopic genetic fragments just diffuse across the capillary walls and get swept into the systemic circulation.
We call the study of this fragmentomics.
Fragmentomics.
By isolating the plasma from a simple blood draw, we can extract these microscopic messages in a bottle. We run them through our NGS pipeline, and we can literally read the mutations of a tumor located deep inside the cranium or the thorax.
Without ever opening the patient up, the clinical implications of that are just staggering.
They are, especially when you consider how tumors evolve. They undergo rapid Darwinian evolution inside the body.
Right. Say we administer a targeted therapy, and it's super effective. It destroys 99% of the malignant cells.
A tiny subclone of the tumor possesses a random, naturally occurring mutation that just so happens to confer resistance to that specific drug.
And with all the competition suddenly eliminated by the chemo, that one resistant clone just rapidly proliferates and takes over.
Historically, we wouldn't even know the drug had failed until that resistant tumor physically grew large enough to appear on a follow-up CT scan months later.
Months later, and for all those months, the patient would be suffering the severe toxicities of a chemotherapy drug that was no longer even working.
It was essentially poisoning them for no benefit. But now, with serial liquid biopsies, we can monitor the nicotinamide A dynamics every few weeks.
So if we detect a new resistance mutation just starting to emerge in the plasma,
we can pivot the therapeutic strategy instantly. We drop the failing drug, we start a new one, essentially staying one step ahead of the tumor's evolutionary adaptations.
we are capturing the spatial and temporal heterogeneity of the disease, and we never even needed a scalpel.
It's incredible.
It really paints a picture of a utopian medical future, doesn't it? Continuous, non-invasive monitoring. Perfect, customized pharmacological interventions.
It does, but this is where we have to severely ground the conversation.
Right, because reality isn't a utopia.
No, the technological brilliance of fragmentomics collides violently with the socioeconomic realities of global healthcare.
And this intersection, this is really the core of your advisory work at Skill Hub in Kenya, isn't it?
It's exactly what we deal with. We are training this brilliant, dedicated generation of laboratory scientists in Kenya, technologists who deeply understand the molecular biology of these NGS assays.
They know the science inside and out.
They do. But the stark reality is that high-end laboratory infrastructure requires massive capital investment.
Right. When you have a healthcare system operating under severe resource constraints, where even getting standard, reliable immunoassay reagents can sometimes face supply chain disruptions.
The prospect of implementing a fully in-house, next-generation sequencing facility feels light years away.
Because it's not just buying the machine, is it?
Oh, not at all. The capital expenditure for the sequencers is just the beginning. You need specialized cold chain logistics for the highly sensitive regions. You need the high-speed computational infrastructure for the bioinformatics we talked about.
It's a colossal financial barrier.
It is, and consequently, the standard of care bifurcates globally.
The gap widens.
Immensely. If a patient presents with an advanced malignancy in a high-resource center in Europe or North America, their tumor is immediately sequenced.
They are prescribed a highly specific, targeted therapy that minimizes side effects and maximizes their survival window.
But in a low-resource setting, due to the prohibitive cost, which frankly can equate to several years' salary for an underinsured patient, that genomic map remains locked behind a financial paywall.
So the clinicians are forced to just rely on older, traditional, generalized chemotherapy protocols.
It's carpet bombing instead of a sniper strike.
And the patients inevitably suffer worse outcomes, higher toxicities, and lower survival rates. Not because the science doesn't exist to save them,
but simply because the diagnostic map is just too expensive to draw. It creates a harrowing ethical dilemma at the lab bench.
Knowing the life-saving data is literally suspended right there in the plasma, in the tube you're holding, but you lack the financial key to unlock it.
It is heartbreaking. And yet, even in the high-resource settings where the technology is abundantly accessible, we face a completely different, equally perilous ethical crisis.
The psychological toll of hyperdetection.
Yes. Liquid biopsies are becoming incredibly, terrifyingly sensitive. They can detect microscopic trace fractions of mutant DNA.
Which means we are inevitably going to start detecting indolent microtumors in completely asymptomatic, healthy people.
Okay, let's clarify indolent for everyone listening.
Yeah.
Because the general public assumes that every single mutated cancer cell inevitably leads to a terminal, life-ending mass.
Right. But human biology is constantly making errors. Our cells mutate all the time.
Often the immune system just recognizes the rogue cell and quietly eliminates it.
And other times, a small cluster of malignant cells does form, but their biology is just lazy.
Indolent. They divide so incredibly slowly that if left completely alone, they would never cause any physical symptoms or impact the patient's lifespan whatsoever.
Exactly. The patient would happily die of old age with the cancer, not from it.
Microscopic papillary thyroid carcinomas are a classic example of this, right? Or low-grade prostate cancers.
Prime examples. But if a highly sensitive, routine liquid biopsy flags that tiny amount of mutant DNA when the patient is 45 years old, we instantly trigger the overdiagnosis cascade.
We take a completely healthy person and we irrevocably label them as a cancer patient. And we fall prey to lead time bias. We haven't actually extended their life one single day. We've just aggressively expanded the amount of time they have to live with the terrifying knowledge of the disease.
And the medical reflex is always to treat, isn't it?
Always. We subject them to surgical excisions, harsh radiation protocols, chemotherapies.
Inflicting severe iatrogenic harm, medical trauma, just to eradicate a tiny cluster of cells that was realistically never going to hurt them in the first place.
This is exactly why the whole concept of informed consent must radically evolve.
Historically, a blood draw required pretty minimal consent, right? Roll up your sleeve, we're going to check your cholesterol, maybe your kidney function.
Right. But now, we are drawing blood to open a literal genetic Pandora's box. Healthcare providers have an immense, heavy ethical burden to rigorously counsel patients before that needle ever breaches the vein.
The patient has to truly understand that finding a mutation in their plasma does not equal an immediate death sentence.
And even more chillingly, they have to explicitly consent to the possibility of incidental findings.
Incidental findings. Give us some example of how that plays out.
Okay. Say we run an NGS panel to profile a patient's suspected lung nodule. But while we are looking at the data, we accidentally discover they carry a germline BRCA or P53 mutation.
Oh, wow. So you haven't just diagnosed them.
No, we've just diagnosed their siblings and their children with a massive lifetime risk of cancer.
The psychological weight of that genetic legacy is just crushing.
It demands a level of genetic literacy from the general public that, honestly, simply does not exist yet.
We are asking everyday patients to navigate a minefield of statistical probabilities, false positives, variants of unknown significance, and the terrifying ambiguity of having an indolent disease.
It is a profound paradigm shift in medicine.
It really is. I mean, we began this entire deep dive at the lab bench just looking at that 7.5 PSA result.
A single flawed number.
We explored how the biological noise of benign conditions like BPH or prostatitis can totally mimic a malignancy, proving that a single biomarker in isolation is just a dangerous illusion.
And we charted the necessity of longitudinal tracking, using pharmacokinetics and half-lives to let time filter out those false alarms.
We broke down the immense mechanical vulnerabilities of the pre-analytical phase, demonstrating how a clumsy phlebotomy draw causing hemolysis can physically blind our most sophisticated immunoassays.
We analyzed the precise sandwich chemistry of ELISA and the catastrophic risks of antibody cross-reactivity and that weird hook effect.
And then we crossed the molecular frontier, moving from the analog detection of proteins to the digital sequencing of ctDNA.
Unveiling the breathtaking potential of fragmentomics and synthetic lethality with PARP inhibitors.
Finally, we confronted the immense collateral damage of all this progress, the stark financial disparities that lock low-resource populations out of personalized oncology.
And the paralyzing anxiety we inflict on patients through the overdiagnosis of indolent microtumors.
We have thoroughly shattered the comforting illusion that a medical test is a simple binary of healthy or sick. We live in the diagnostic muddy waters. But as sequencing costs inevitably drop and AI algorithms become terrifyingly proficient at filtering out all that biological noise, we are accelerating toward an inescapable horizon. I want you to imagine a decade from now sitting in your primary care clinic. You are offered a routine, inexpensive liquid biopsy, a single tube of blood that will map your entire molecular destiny, predicting every malignant mutation hiding in your DNA long before the first rogue cell ever divides. You know the history of false positives. You know the crushing anxiety of carrying a genetic time bomb and the absolute chaos of discovering a cancer that might never actually harm you. If that ultimate all-seeing diagnostic map is placed on the table in front of you, would you really want to read it?